I'm just sharing my screen. Give me a second. Yeah. Thank you very much. And I think after that mammoth session on COVID, influenza is going to be like a revision topic in your MD examination, because the recent advances have been covered very well by Dr. Balasubramaniam and team. And now let's go back and look at the old horse, the influenza vaccine.
Daddy.
So, there. Right. So we have very knowledgeable panelists, Dr. Karthikeyan, Dr. Nandini, and Dr. Soma Sivabalan. And to make things a little spicy, this is going to be a kind of a 2020 match. We are not going to go into too many details because we just want to refresh the memory and try to bring some of the recent advances as far as influenza is concerned. So let's start with the virus itself. So I'm going to break it up into the virus, the vaccine, and the implementation. So starting with the virus quickly, let's go to Dr. Karthikeyan. What are the types of influenza viruses and the relative burden of each?
Thank you, sir, and good evening to all of you. So as we know that influenza can be caused by 4 types of viruses, A, B, C, and D, of which luckily D doesn't seem to infect humans, and C is quite rare. It is not a public health problem. So our main concern would be this influenza A and B. So out of this, sir, can you move on to the next slide? So the influenza A and B, structurally they are very similar, but the only thing that gives an advantage to influenza A is that it has got a lot of non-human hosts and reservoirs. So there is an ample opportunity for influenza A to keep changing its heme agglutinin and neuraminidase antigens. That gives it an edge to sustain its spread. And influenza B has a heme agglutinin neuraminidase similar to influenza A, but as it is there only in a human host, it doesn't undergo that kind of a variation as it is seen by influenza A. We can see that influenza A has 18 types of heme agglutinin and 11 types of neuraminidase. And influenza B we classify into lineages Yamagata and Victoria. And of influenza A, that is very relevant to our disease prevalence is H1N1 and H3N2. And influenza B, Yamagata and Victoria.
Thank you, Dr. Karthikeyan. May I just also tell here that if any of the other panelists want to come in at any time, they can just come in and comment. So now, what are the basic problems as far as type A and type B is concerned? Initially, we thought that only type A produced significant disease, but we now know that type B also is important. So can you just come and give us a little bit about type B also?
Yes, sir. Various data shows that like type B has also been significant. Many years when we see type B has produced as much infection as type A. The only thing is type A alone produces the pandemic because it produces a major structural change in the viral neuraminidase and hemophilus and the heme agglutinin, whereas our type B doesn't produce a major antigenic change, but it also produces an antigenic drift. So that is the reason why each year we need to keep changing the component of the virus with regard to type A and type B. And therapeutically also, your amantadine, rimantadine might not be effective against type B, whereas your oseltamivir will be acting against both your type A and type B.
So you would agree that both type A and type B are significant pathogens as far as children are concerned.
Yes.
And type B has got a little more predilection for pediatric age groups. So it's an important pathogen as far as children are concerned. Coming to the problem, yes, we hear about influenza in all over the world. In the US, it's a big problem because they have influenza camps, etc. Is it an epidemic disease here? Is it a seasonal disease? Is it an endemic disease? What kind of a problem? Do we see it in certain seasons or through the year?
Yes, sir. The seasonality of influenza is very important because it only decides what time we need to time our vaccination. Just like the vaccine virus, the timing of the vaccination is also going to be very important. So the advantage of temperate regions is they have a characteristic seasonality. Like for Northern Hemisphere, most of the disease happens between November and March. And for Southern Hemisphere, most of the disease happens between May and September. So they give a vaccine that is made for that season and it is very effective there. But whereas in contrast, if we take the tropical and subtropical region, which are close to the equator, we see that there is a year-round activity of influenza, And among that, there are seasonal peaks. And when we see that the seasonal peaks of influenza keep varying within the country. Even if we take India as a single entity, the seasonal peaks in different parts of the India are totally different. Can we go on to the next slide? So this shows that in 6 places, there was year-round activity. For each month, there is a year-round activity, but the seasonal peaks happened in different times. And can you move on to the next slide, which nicely shows that? Yeah, this is a very nice slide which tells what is the peak seasonality. And from this slide, they have come to the inference that the seasonality depends first on the latitudinal location. So any place which is north of the 30°, they say that they follow the pattern of the northern hemisphere. So the peak cases happen between December and February. Anything that is south to the 30° north latitude, there the influenza seasonality is more decided by the monsoon. So whenever there is a monsoon, that time they have more cases. Fortunately, most parts of India, the monsoon happens somewhere between June to September or October. So most of the time, though India is there in the northern hemisphere, the southern hemisphere vaccines will be ideal for those places for the majority. And notable exceptions are the southern places like Chennai and Vellore, where again, because we know that the monsoon happens after October, there the peak seasonality happens in November and December. So again, that time of the year, the northern hemisphere vaccines would be the most relevant.
So this chart is very important to note that the most of India, if you look here, the peak is around July, September, May, July, September. Whereas there are only two or three areas where you will find that this is in the December, February, November, December, February area. And this is very important to note because the vaccine works best when it is given at least about 4 to 6 weeks before peak seasonality. And therefore, one should remember that these are the peak seasonalities in our country. Thank you, Dr. Karthikeyan, for bringing it out so beautifully in this slide.
Thank you.
So are there any epidemiological studies from India which also look at the burden of influenza in India?
Yes, sir. The epidemiological studies are picking up in a quite significant way. Previously, the recommendations were extrapolated from the Western data. After the 2009-10 pandemic, there has been quite a lot of epidemiological studies. We have the NCDC, which gives us very good statistics. So this is a statewide statistics, and it also tells about the case fatality rate. And in addition to government, there are a lot of other studies which are being done at the national level as well as at micro level. Now we have studies for each state. Like there is a study in Odisha which has assessed the influenza pattern for 7 years, and there is another study in Andhra Pradesh. So the micro level studies are also coming up nicely, but still we are far behind. We need to strengthen. Now that secondary to COVID, the RT-PCR capacity of our country has strengthened nicely. I think in future, there'll be more amount of testing when it becomes more accessible and affordable. And then we will be having very reliable data, which can guide us exactly regarding the immunization for the different parts of our country.
Thank you, Dr. Karthikeyan. I think COVID woke us up and,
Yes,
we started testing extensively. And same thing happened during the H1N1 pandemic, where we were testing at, almost every single case who came with fever, cold and cough. So I think India needs a pandemic to start testing extensively.
Yes,
and with the more and more availability of RT-PCR, I think influenza testing is going to be, point of care testing is going to be the way forward. So another study, you want to comment on this?
Yeah, these are this is a study which assessed across 7 Indian states from 2014 to 17, sir. So I just put these studies to say that there will be a lot of micro level studies. So regionally, it gives us a lot of data regarding the regional changes. I mean, there is another study that has been posted from Andhra Pradesh.
Thank you, sir. I'll skip this if you
Yes,
don't
sir.
mind and move ahead. What is this antigenic shift and drift, and why does this WHO want to make vaccines every year, or at least
Yes.
give advice to make vaccines every year?
Can we move on to the next slide, sir? Antigenic shift refers to a large level change in the genetic material, whereas antigenic drift is a small level change in the genetic material. So whenever there is an antigenic shift, the structure of the virus totally changes, and it means that most of the people will be susceptible. Whereas in an antigenic drift, the structural change is there, but depending on the change, there might be or might not be partial immunity for a strain. So when we go to the next slide, the antigenic shift is for example, if you see that this avian flu has got a very high pathogenicity or a very high case fatality. But the problem with the avian flu is it is not able to bind to the human epithelium. Whereas the seasonal flu is not very pathogenic, but it is easily able to bind to the respiratory epithelium. So what happens is when these two viruses coexist in a host outside the humans, there is random exchange of genetic material so that the new strain is produced, which has the high virulence of the avian flu and which has the easy infectivity of the seasonal flu. So this gives it a very good edge to survive. And once it comes out into the human race, the whole population of the world is susceptible. Whereas what happens is after some time, due to natural immunity and due to our vaccines, as the immunity starts build up, these viruses still try to escape from this immunity pressure by going in for what is called as an antigenic drift, where there is a small level mutation which produces a small level structural change in the hemagglutinin and neuraminidase surface proteins.
Thank you, Dr. Karthikeyan. I think what you have brought out beautifully is that when there is intermixing of a large amount of genetic material outside the human host, like for example, it can happen in avian flu or bird flu, which is commonly seen, and then it affects it's basically an antigenic shift, and smaller mutations keep taking place after that, which is a antigenic drift. So therefore, usually an antigenic shift will produce a pandemic of illness with a large amount of deaths because the human has not faced this kind of a genetic virus in the past. However, a drift will not produce a major pandemic. Thank you. Is influenza any different from other respiratory viruses? Why are we giving so much importance to this virus? There are so many viruses like RSV and rhinovirus and adenovirus, but we are very focused on influenza. And why is that?
Yes, the one thing is clinically it is very difficult to differentiate, though there are a lot of symptoms which are mentioned. Most of the time they are non-specific, and clinically only a severe case of influenza we may be able to suspect. Otherwise, influenza can be asymptomatic or it can be mildly symptomatic when it will look like just some other respiratory virus. The importance is in the fact that influenza can produce a lot of complications, especially in the particular age groups, especially in small children less than 5 years, and in pregnant women, and in the older age group, and in people with comorbidities. Compared to other viruses, the effect of influenza in producing a severe illness in these high risk groups is very significant.
Thank you. Thank you, Dr. Karthikeyan. Yeah. I think the key difference between the influenza virus and the other viruses that influenza virus is a cytotoxic virus. So that means it destroys the cell. When it destroys the cell, there is a very high propensity for bacterial superinfection. And that's why if you look at even the pandemics, many of the pandemics, deaths can be because of superinfection due to pathogenic bacteria. So influenza is basically a cytotoxic virus, and that itself is a major issue. Thank you, sir. Then we'll move ahead now. Can we just comment quickly? I think we are now moving on to Dr. Balasubramaniam's area. During this period of COVID, influenza had virtually disappeared from the world.
Yes, when we even go through the NCDC statistics, there has been a very significant drop in influenza for the last year. This is mainly because people have been confined indoors, and as part of the COVID, the personal protection has improved to such level, and travel has been restricted. So all this has contributed to a very significant decline in influenza cases, which has happened in the last 1 year. And when we compare influenza and COVID, influenza has a shorter incubation period and a lesser period of infectivity compared to COVID. The only fortunate thing is COVID in children is less severe, and the complication rate and risk of hospitalization when we compare with flu is very, very less. And having told that, one of the points is children with comorbidities are prone to develop a lot of complications with both the COVID and the influenza.
Thank you, Dr. Karthikeyan. So which age groups? I think you think all children are equally affected, or is it particularly some groups who are seriously affected with influenza?
Yes. So coming to the question, first I thought the elderly are one very high risk group. So we know that 75% of seasonal influenza related hospitalization and 85% of death due to seasonal influenza happen in more than 50 years. And the reasons told or the age-related immunosenescence, there is a massive decline in adaptive and cell-mediated immunity, and they have a lot of associated comorbidities. They are on steroids or chronic drug intake. They have obesity. And the main problem with the elderly is they don't present as classically as they present in a younger adult. So most of the time, the influenza in elderly presents like a exacerbation of an underlying illness. They presume that it is just a worsening of the underlying illness. Actually, influenza is what is causing the worsening of the illness. So we need to have a high degree of suspicion. And the recent WHO guidelines on influenza vaccination, there was an interim guideline in September 2020, which told that instead of the previous recommendation to vaccinate elderly above 65 years, because of all the risks involved in elderly, they have brought down the cutoff for elderly to 50 years in comparison to the 65 years cutoff, which was there in the previous 2012 recommendations. And the next high risk group is, as we know, pregnancy. Pregnant women are 7 times more likely to be hospitalized and 2 times more likely to die. And we all know the reasons for that. There is a suppression of cell-mediated immunity as a part of the immunotolerance, and there are a lot of features like a decreased lung capacity, increased blood volume. So pregnancy, already the mother is in a compensated state. So if they get influenza, they develop a lot of complications. And the pediatric point of view, it gives a poor fetal outcomes. And less than 6-month-old child, the maternal antibodies are the only source of protection. So if pregnant mothers are vaccinated, they will get protected. And when you see in children, like the question that you asked, so though less than 5 years are taken as high risk group, most of the infections happen less than 1 year. And of that, 2/3 of the infections happen in less than 6 months. The reason for this is the child has to develop immunity by a priming and a boosting, which should happen either due to a natural immunity or due to a vaccine. So as age advances, this boosting happens in a significant way. So the younger children are more likely to develop severe complications.
Thank you, Dr. Karthikeyan. Very quickly, give us the principles of prevention of influenza because we are running short of time.
So the principles of prevention, now that with the COVID, I think almost everyone is familiar with all the precautions that we need to take with respect to washing of the hands and avoiding touching of the eye, nose, and mouth, to maintain a social distancing. In addition to these personal protective measures, the vaccination is the mainstay of protection. So we should advise vaccination, especially for the high risk group, if not to all people. And one another part of prevention would be the chemoprophylaxis. Though there are a lot of controversies, there are selected indications to give chemoprophylaxis in case if there is a susceptible contact.
Thank you, Dr. Karthikeyan, for that excellent review of the influenza virus, the A type, B type, the antigenic shift, drift, and peculiar ages when it is particularly a very severe disease. Now we'll move to the vaccines. And for the vaccines, we have Dr. Nandini coming in now. Dr. Nandini, what are the types of influenza vaccines?
Good evening to one and all gathered here, and thank you TNSC for the opportunity and to Dr. Balasubramaniam for the coordination. There are 2 types of influenza vaccine. One is the inactivated influenza vaccine, which is called as the IIV, and the live attenuated influenza vaccine, which is the LAIV. But in use in our country at present, we have only the IIV. And IIV uses the killed viral components, and this is given intramuscularly. Whereas the live attenuated one, it is the attenuated weakened influenza virus, and which is given as an intranasal spray. As the LAIV is not available at present, because it is also shown to have a lower effectiveness against the H1N1 influenza A. And apart from this, of academic interest, we have also other types of influenza vaccine. One is the recombinant influenza vaccine, RIV3, I have indicated, but we have also an RIV4, which is called as the Fluzone, that is Flublok Quadri. This is nothing but this is an egg protein-free vaccine. But however, it is not licensed for use in children. It can be used only above 18 years of age. I will tell you the indication of it later. Apart from this, we have also a that is high dose influenza vaccine, which has got the influenza antigen 4 times the normal. Normal antigen is about 15 micrograms, and this contains 60 micrograms. And this is called as Fluzone. And this is mainly meant for individuals above 65 years of age, because they are generally above 60 or 65. You are immunosenescent. Your immunogenicity or your reaction or immunogenic response to the vaccine will become less. So you have a higher antigenic load to produce a better response. But these two vaccines, both the recombinant as well as this high dose influenza vaccine, which are meant for elderly above 65 years, at present is not available in India.
Thank you,
Next.
madam. And I think just out of interest, the first vaccine for influenza was a live nasal vaccine from Russia, and it was being used till very recently. Now, madam, there is also this trivalent and quadrivalent vaccines. What are these kind of things? Because, I mean, the practitioner is confused because somebody says, you know, the trivalent vaccine is cheaper and you give that, quadrivalent vaccine is not easily available. So what is your take on this?
Actually, as Dr. Karthikeyan already mentioned during the virus, he told us the types of the virus. So we have the influenza A as well as the influenza B virus. The next slide, sir. The trivalent vaccine, which is the IIV3, this has got 2 strains of influenza A and 1 strain of influenza B, and therefore it is said to be trivalent. But now we have, recently in the last 2 to 3 years, we have the quadrivalent vaccine, which has got 2 strains of influenza A and 2 strains of influenza B. And we will tell you, because quadrivalent vaccine, as of now, this is just the presentation of the Northern Hemisphere 2020-2021 thing, which contains 4 of these things. That is 4 quadrivalent is, it is 2 of influenza A and 2 of influenza B. Next, and this is a split virion vaccine. Just next. And why should you have a quadrivalent vaccine?
Your voice is gone, ma'am.
Am I audible, sir? Now?
Yes.
Yeah. The next one, why is a quadrivalent vaccine needed? Because initially, only when a trivalent vaccine was available, which had 2 of A and 1 of B, it was found that the B1, as Dr. Karthikeyan had mentioned, which are the Victoria and the Yamagata lineages, can co-circulate. And it was found that globally, about 20 to 30% of the isolates were getting to be B. And the trivalent had only 1 B strain. And both the B strains can sometimes circulate simultaneously during a season within the same country or according in a region or in a hemisphere. So one strain would not give a good protection. So there was a need to have both the two, that is both the influenza B, and that is how trivalent became quadrivalent. Moreover, influenza B disease burden is very significant. It has got a more increasing disease in children. And it is very difficult also the clinical features of B are very indistinguishable from that of A, and it is mainly seen in the pediatric age group. So it is definitely necessary to broaden the protection by using from trivalent to a quadrivalent. And sometimes when trivalent vaccine was used, which had only 1 B strain, the circulating B strain would be a different one, in which case there would be even a mismatch of the vaccine and the strain that is producing the disease. So broadening from trivalent to quadrivalent by having 2A influenza A and 2B influenza virus will broaden the protection and therefore will be helpful in bringing down the disease burden in the community. Next.
Thank you, ma'am. The other problem is this Northern Hemisphere, Southern Hemisphere strains. I think India is a very peculiar country because we have both vaccines, both types of vaccines available. And the practitioner, you know, he's finished using the Southern Hemisphere vaccine and the representative comes and tells him now the Northern Hemisphere vaccine is available. So there are parents who come and says, why do you want to vaccinate my child twice a year? So what would be your take on this?
Yeah, like though we are geographically located in the Northern Hemisphere above the equator, can you show the next slide, sir? Project the next. Yeah, we are, that is by location in the Northern Hemisphere. So in the Northern Hemisphere, if you take, which are the temperate climate regions, you find the peak of the disease. Actually, each block is from January to December. You find the peak of the disease is more towards winter. That is, it starts from November, December to Jan, Feb. So these 4 months, that is the winter peak is the more seen in the Northern Hemisphere. These are the countries with the temperate climate. So India, as was stressed by Dr. Jagdish Chinnappa earlier, it is only the Delhi as well as the Srinagar, Jammu Kashmir area, that part of Northern India that falls into the Northern Hemisphere location. Whereas if you see in the tropical region, you will find that the disease is almost there throughout the year with small peaks of disease in between. And it is said that it is almost 3 to 8% of the population, they have influenza disease almost continuously. So it is a perennial problem. And in the Southern Hemisphere, it is related to monsoon. So it starts off in the month of, actually the peaks are mainly in the month of May, June, July, August, September. So those 4 months are there. So it is very important to know though we have, India itself is so peculiar, though we are in the Northern Hemisphere, we see the diseases of both the Northern Hemisphere as well as a tropical or a Southern Hemisphere. So it is necessary to understand this so as to place the timing of the vaccine. Next. So this is the dynamics of the influenza seasonality, because it has got an implication in choosing the timing for the vaccine. And it is said, as we see, that is, if it is a winter months where the disease is going to start off, as if you see the northern hem, that is the Jammu Kashmir, whereas if you come also towards Chennai and Tamil Nadu area, where the monsoon is almost in about August, September, October, we start vaccinating almost 4 weeks before the season, because you have to give an antibody response before the season starts. Whereas in states where the monsoon effect is in June, July, August, September, they vaccinate in the month of April and May by using the Southern Hemisphere vaccine. So both IAP as well as WHO, what they recommend is you must start the vaccination based upon the region, and you must vaccinate 2 to 4 weeks before the beginning of the season. I would say even 2 weeks is not sufficient. I think we should take it to 4 to 6 weeks before the onset of a season in a particular area. And this is so geographically very different, because I told you how India is so diverse in its seasonality and the disease or influenza distribution throughout the country.
So if I understand right, in Bangalore, I would give the vaccine in May, and in Chennai, you would give the vaccine in September, October. Am I right?
Yes, sir. Yes, sir.
Okay. So which is a very, I mean, we are just a few kilometers away, and we have such varied recommendations. Okay. So I think if we skip this, ma'am, this is very similar.
This is the same. We have already gone through.
Now, child with egg allergy, can you vaccinate?
Yeah, we know that this influenza vaccine is being prepared from the, that is the hen's egg. And this has got traces of ova-albumin, which is said to be the allergic component. So people who have an egg allergy, you just try to find out by history, what is the type of the allergic response. If it is just a mild allergic response like an urticaria or a hives, there is no absolute contraindication. You can administer the influenza vaccine with precondition. What is the precondition? That means you must do it in an inpatient setup, or you have to have an observation after the vaccine for about 30 minutes, and you must have all the facilities to handle if an anaphylaxis were to happen. That means you must be well equipped. So, but you should go and continue giving a vaccine to the child. But however, if the child gives a history of egg allergic reaction in the form of respiratory symptoms like wheezing and edema and respiratory compromise, and then also cardiovascular compromise like hypotension, and child also had persistent vomiting due to GI manifestations, and this child in such an event warranted an administration of the emergency medicine like epinephrine. In such a child, you should think twice before vaccinating this child. You have to have a discussion with the allergy specialist. And here is the indication for using, I told you about the one academic interest vaccine, RIV4, which is the recombinant influenza vaccine, which is prepared in such a way it is egg protein free. And therefore that vaccine RIV4 can be used, but it is not available in our country. Only thing is the indication is only after 18 years. Therefore, in the pediatric age group, we cannot use this.
Thank you, ma'am. What about gelatin and thimerosal? Are
Yeah,
they of concern, or should we just pass them off?
That is a gelatin is nothing but a stabilizer that is used in a vaccine. This is a material that is used to give the prevent the potency of the vaccine from coming down. This gelatin was present in the nasal flu vaccine. But however, now we don't have the nasal flu vaccine. So whenever a patient gives a history of food allergy to gelatin, you must be careful, especially because they may develop anaphylaxis after receiving a gelatin containing vaccine and has to be avoided. But since we do not have the nasal vaccine, there is no problem at all. And what is thiomersal? Thiomersal is nothing but a preservative that is present in multi-dose vials of vaccine. This is to prevent microbial contamination, because repeated penetrations to draw the doses may result in microbial contamination. So that is of concern. But however, since our influenza vaccine are all unit dose vaccines, we do not have thiomersal, so there's nothing to be worried. Moreover, this thiomersal, that is related to ethyl mercury, and it is not methyl mercury, which is the toxic one. And when thiomersal is present in a vaccine, which is not there in influenza, there is no evidence that it has got an increased risk to neurodevelopmental problems like autism. This is just of interest, but both these gelatin and thiomersal are not of relevance to our influenza vaccine because they do not contain it.
Ma'am, quickly, can you just tell us what is the difference between the subunit and split virion vaccines?
Yes,
are they
yes,
really
sir.
of great significance that we should know the differences? Or
it is important, sir. It is important because if you see the structure of the vaccine as is already seen, actually now looking at the influenza structure, we are reminded of COVID also, because the same size sort of spikes and crowns are there. You know that this is an RNA virus and it has got an outer protein, inner protein layer. So just the previous one. And it has also got an outer lipid layer, which has got from the outer lipid envelope only, you have the heme agglutinin and the neuraminidase, which also Dr. Karthikeyan had already elaborated. And this is going to give the H and the N. That is going to determine what is the type of the influenza virus. Next. We have the live attenuated influenza vaccine, which is not in use now. So in the inactivated influenza vaccine, we have the whole virus. This was the whole virus which was used earlier in 1970s when the influenza vaccine came into use. But however, this whole virion vaccine of inactivated influenza is not available. So what do we have now? We have only two types of influenza inactive vaccine. One is the split virus and the other is the subunit. What is the split virus? The split virus is, it has got particles of the influenza virus, all the particles, both the surface particle as well as the internal antigens, whereas the subunit vaccine has only the external antigens or the surface antigens. Next. So as we say, the split virion vaccine has got surface antigens, internal antigens, and it is said to be highly immunogenic and highly tolerated also. Whereas a subunit vaccine, which has got the surface antigen only, it lacks the internal antigen. It does also have an immunogenic response, but it is lesser. So what is the implication? Split virion vaccine and subunit vaccine, both are available, but in a naive child under 3 years, when you're using the vaccine for the first time, it is better to use split virion vaccine with more antigenic content, because it has got a higher immunogenicity.
Again, this new concept which has come now about 0.25 ml, 0.5 ml, various manufacturers saying 0.5 ml is required under 3 years of age. So what would you recommend here, ma'am?
That is, if you see the schedule for the influenza vaccine, the inactivated influenza vaccine, the dosage is from 6 months to 9 years. You have to give, when you're using it for the first time, it is 2 doses, 4 weeks apart. Above 9 years, it is a single dose. And when you revaccinate them the next year or subsequently, it is only a single dose at all ages. And earlier, the recommendation was from 6 months to 36, 35 months is to give half the dose. That is 0.25 ml, which is called as the pediatric influenza vaccine. And any child from 36 months of age, you give them the complete full vaccine, that is 0.5 ml. But now there is a change. We'll go to the next. This is the recommendation. It has come from the ACVIP IAP immunization schedule of 2020-21, where it is said inactivated influenza vaccine, a uniform dose of 15 microgram, that is 0.5 ml of inactivated influenza vaccine is recommended for all children older than 6 months. Why did this ever happen? Because earlier, when the influenza vaccine was being used, they had the whole virion, that is, and that produced increased immunogenic response in the form of febrile reactions and high reactogenicity in children under 3 years. Therefore, that 15 microgram dose was brought down to 7.5 micrograms, and therefore only 0.25 ml was being used. But however, now with the advent of more advanced formulations like the split virion, etc., and they found that when a 0.25 ml of dose was used, the immunogenic response to the various influenza, especially the influenza B, was less. And we know the influenza B disease has got a high impact in pediatric age group. And therefore, they felt that 0.025 can be increased to 0.5 because it became more immunogenic. And because now the vaccines are all split virion vaccines, the reactogenicity is also low. Therefore, to get a better immune response with less reactogenicity and to get the benefit of better protection for both A and B equally, now the ACVIP has made that uniformly from 6 months onwards itself, there is a uniform dose of 0.5 ml only. And the DCGI has approved it for 2 of the split virion vaccines. It is awaiting for approval for 2 other vaccine manufacturers.
Thank you, Dr. Nandini. That was very well explained. And now we'll go to the last section of our panel discussion. And we have Hardik Pandya, Dr. Somu Sivabalan. Dr. Somu Sivabalan, are you there?
Yeah. I'm there very much.
So now we are at the tail end, and now we have to show the last of the 50 overs. We have to see how fast you can go ahead now. What to do if the vaccine is frozen, Dr. Somu?
Straight answer is don't use it, discard it. Why? Because inactivated vaccine should not be frozen. We don't have that, many of them don't have that ILRs, and they use a traditional commercial refrigerator. If it is stored near the freezer, probability of they getting frozen are there. When they are frozen, the potency is being lost permanently. It is not that when you get back to liquid form, the immunogenicity comes back. It doesn't. So frozen vaccine loses its immunogenicity, and the likelihood of causing increased reactogenicity in the form of sterile abscesses are there. So discard it.
What is the efficacy of the current vaccine? As I can see in many of the studies, the efficacy is not very high. So how would you comment on this?
We are speaking for 40 to 60 minutes, but the efficacy is also around 40 to 60% only. During the season, most of the time, when the circulating type and the vaccine type are very well matched, that is the thing. And otherwise, it can come down further. When the trivalent was there, when there was a 25% mismatch of the Yamagata and the other strains of B strain, so there was a lineage. There was even the percentage was still lower down. So overall, it is around 40 to 60. To be on the safer side, patients might be alarmed. We can always say it is around 70%.
So that means I think the most important thing is to use the quadrivalent vaccine. Please don't use the trivalent vaccine because efficacy will be very low. Which are the brands available in India and their properties? Any quick take on this?
Though we are all talking about epidemic, endemic, whether it is seasonal, but I would rather say it is an endemic disease with seasonal epidemic. So when the seasonal epidemic happens, then a lot of smaller company and players come into play. Most of the time, it's the 4 major ones. One is the Influvac Tetra, which is the Abbott vaccine. It's important to note that is only the subunit vaccine available. And Fluarix Tetra is from the GSK, and Flucodri from Sanofi, and Vaxiflu 4 vaccine from the Zydus Cadila. Here it is important to note that only one is a subunit vaccine, remaining all are the split viral vaccine. And GSK and Abbott has been approved for 0.5 for now, whereas the other 2 are still coming with the 0.25 and 0.5 ml, though IAP has recommended 0.5.
Thank you, Dr. Somugh. Do you vaccinate parents and grandparents in your clinic?
Yes, I do, because even for kids, I don't vaccinate. It's only the immunization system, because I'm an institutional based person. And in our institution, it's both a combination of where I practice in the evenings, it's a combination of adult and pediatric practice as a hospital. So they do vaccinate more so in the epidemic phase, when parents and grandparents are vaccinated. It is more for their personal protection, meaning they are less likely to get, and also for herd immunity. Though we heard COVID vaccine is not for herd immunity, here flu vaccine can be given for herd immunity because it breaks the chain of transmission. I don't know the reason why COVID should not act as a herd immunity, because that again breaks the chain of transmission. And in less than 6 months of age, they have very serious manifestation and complication where they cannot be vaccinated. So ideal would be to vaccinate the pregnant people, and also the cocooning effect, meaning household people. Most of the time we say family members, the family member might be abroad, so they'll be vaccinating them, but not the servant or the car driver. So it's a household contact, they have to be vaccinated. That will include anybody's parents and also the grandparents.
Excellent. Any comments on the IAP guidelines? I think we
As
have
said earlier, IAP, they have strictly said till 5 years, everybody should be vaccinated. And ideally, when anybody is hired for a job, his duty starts immediately, and the salary roll also comes in immediately. Whereas with regards to the vaccine, they don't act immediately. They take a time frame. They say at least 2 weeks from the dose given, they start to act. So ideal would be anybody and everybody should be vaccinated. If at all, if not, at least the high risk individual and children less than 5 years have to be vaccinated.
Thank you. Child received only 1 dose last season and comes again this year. What do you do now? Do you give 2 doses or 1 dose? This child is
See, if
3
it
years
is
old.
less than
Yes, 3
9
years old.
years,
3 years
if it is less than 9 years, if only 1 dose has been given in the previous season, meaning if the time gap is more than 6 months, ideal would be to start 2 doses. Why? Because if a single dose is being given, again, the chance of vaccine efficacy, already I told you it's only 40 to 60%, it can come down further. It is more only in less than 8 completed years. Why? Because after that, the immunogenicity is much better. Here they say the first dose acts as a immune primer, and the second dose really acts as a immune stimulator or a booster. So that's the idea of giving 2 doses. But here again, if it is 2 doses given anytime in the past, maybe 1 year ago, to 1 more dose 3 years ago, if more than 1 dose at any point in time is given before, then you cannot call it as a 2 different incomplete dose and start with 2 doses again. They can go with the 1 dose. That is the recommendation.
Thank you. Any recent advances regarding influenza vaccine?
Most of the thing Dr. Nandini has already said, and this is a high dose vaccine for the seniors. Why? Because the immune response in them is not great. And the same in line with that, flu vaccine with a normal dose with an adjuvant, which potentiates the immune response in these individuals have been there. And intradermal flu vaccine, 0.1 ml has been approved for children about 18 years, so that the quantity and doses given can be increased. Quantity is less and the dose given can be increased. And as Dr. Nandini with regards to ecology was been talking about, all our egg-based vaccines, there are also cell-based vaccine and recombinant vaccines which are available, which are in the pipeline, meaning they can be manufactured at the drop of your hat, meaning it can be expedited in an epidemic situation where we again meet the pandemic of flu.
Thank
And
you.
the ideal would be to look in for a universal vaccine, meaning 1 shot like varicella or 2 doses maximum like MMR, and you forget the virus. So they are planning on that, but that's a distant dream.
Just one quick googly to you. Does influenza vaccine prevent COVID?
No, when these two are happening together, the severity of one complementing the other is much more. So whether it prevents COVID or not, it definitely prevents influenza to a certain extent. So as well have them. And co-infections are very much known, and co-infections outcome is relatively poor.
So thank you very much, panelists. I think we've come to the end of it. I'll just run through a few slides on the conclusions. 1, influenza is a significant disease contributing to significant morbidity and mortality in especially small children. Almost 6.5% of all pediatric acute lower respiratory tract infections, deaths in India were due to influenza. There's limited data on burden of severe influenza. 2 strains are there, A and B strains. It's very important to vaccinate against both strains. It's preferable to use vaccines containing 2 B strains, always use quadrivalent vaccines. Start immunization early as per recommendations of the IIP, soon after 6 months. Don't wait till the child goes to school or preschool. Administer influenza vaccines every year at appropriate times, depending on where you stay and what the prevalent strains are. Northern, southern is what you have to decide depending on where you are. Vaccinate 2 to 4 weeks after, allow at least 2 to 4 weeks after vaccination for antibodies to develop, because you should vaccinate just before the season starts. Okay, if you vaccinate right into the season, then there is a chance of reduced protection. So we know that we are still may land up with another problem as far as influenza is concerned, primarily because we have a very naive, immature immune system in childhood. And again, as Madam mentioned, immune competence goes down over the years. So we have two major areas when influenza can be a very severe disease and they need protection. So we can, this is a very interesting article from Indian Journal of Medical Research, which says that pandemic flu 1918, after 100 years, India is as vulnerable as it was before. So thank you very much from all the panelists. Protect your patients, protect yourselves, and protect the senior citizens from influenza.
Dr. Jagdish, just a single comment.
Yes, please.
Though it is called an annual vaccine, the coverage is not for 1 year. After 6 months, the immunity starts waning down. So time yourself properly depending on the epidemiological location where you are in. So know your local epidemiology also. Thank you.
Thank you, Dr. Jagdish and the expert panelists. It is a wonderful discussion. Thank you, Dr. Sivabalan, Dr. Nandini and Karthikeyan for the lucid discussion. There are two questions. One was somebody asked, Dr. Sudha has asked, egg allergy. The child has not received egg at all. How do you know the child is allergic or not? Do you give flu vaccine? Jagdish?
Dr. Nandini, I think this is for you, but I can take the question answer if you want. I think it's very important to keep all resuscitation equipment ready wherever you're giving vaccines. You cannot assume that a particular patient is not going to react to a vaccine because he has not reacted before. So I think the important thing is that if the patient has not had egg, take all precautions and give the vaccine. I'm sure if there is a reaction, you can handle it in your office.
The next question from Dr. Bhuvaneshwari. She says influenza is a mild illness in infants. Why not we give only to high risk? Jagdish, I'm sure you will react to it.
No. I think the important thing to realize here is that though influenza is a mild disease in most children, it is yet one of the most single most important cause of severe viral infections in small children, and therefore vaccination is the only way to prevent children from going into complications because of influenza.
Okay, one last question from me, Jagdish. A 6 months old infant comes to me tomorrow. This is March 2021. Low risk for influenza, low season for influenza. Do I give the first dose of the currently available vaccine, or I ask them to come in October or September or July before monsoon in Chennai?
As I said, you have to follow what is most appropriate in the place where you stay. So if the child came to me in Bangalore, I will defer the vaccination till May and give the vaccine in May, because that is a peak time when the child needs to be protected against influenza in at least this country. The other thing is I would also look at the risk of that child getting influenza. If this child is going to remain in a big joint family, many other children around, then this child is likely to get infected very soon. However, if this child is going to stay in a nuclear family with masking on and social distancing on and breastfeeding on, chances are very low. So I think the point is we need to look at an individual basis and use the vaccine appropriately depending on where you stay.
One last question, Jagdish. There is erratic supply of influenza vaccines from different companies. Okay. On the day my patient during pre-monsoon time comes, do I find out whether it is northern hemisphere, southern hemisphere? What is the expiry date? What is the production date? And give whatever that is there sold by my distributor.
I think this is a very difficult question to answer, and as usual, this is probably Ashwin at his best. So, so I think what we will do is that this is not an easy answer here. So I think what we need to do is to look at giving the most recent vaccine at depending on the risk of getting influenza. If I find that there is a huge outbreak of influenza in the city, I would vaccinate with whatever is available. However, if the general pattern or the epidemiology of influenza in my city doesn't show too many cases, I'd probably wait for an appropriate time to vaccinate.
Brilliant answer, Jagdish. Thank you very much. Jagdish, Shivabalan, Nandini and Karthikeyan, the trio, you did a wonderful job. Thank you very much. Over to Dr. Rajendran for the final session. We are on time.
Yeah, thank you, sir. And it's excellent discussion regarding influenza vaccine. Thank the panelists. Next, I welcome Dr. Vijay Yavale. He's a well-known person and worldwide, and he's consultant pediatrician at